afternoon, everyone. As Mark has already alluded to, this is about the Gynae Assess and Treat Unit at Airedale General Hospital. I'm Sue Speaker, I'm Head of Service Improvement at Airedale, and I was involved at the beginning. Sherry is the matron for day cases, and Sherry took it over and ran with it and has improved it over the last 5 years now. We've been running this, it's been running for. And we've brought with us Helen as well, who was pivotal in actually making it work, and is a staff nurse on that unit. She doesn't want to speak, but we will be sort of perhaps using some quotes that we've got from her, and if you've got any questions, she's the expert at the end. Our problem was that way back in 2008/9, the managers within Airedale Hospital decided that we needed to close some beds. And you know how it is, you look at the numbers at midnight, don't you, and decide that, oh yeah, that looks fine, we could put these patients onto this ward. So what they decided was the midnight bed numbers on Ward 18, which was the gynae ward, would fit into the female surgical ward. And so that's what they did, they closed the gynae ward down. What they didn't realise was that there was hundreds and hundreds of women that came through the unit on a day case basis. And of course they don't collect, they're not collected at night because they're not there, are they? So, you know, and they just didn't realise that all these women would be coming to a busy surgical ward. The other problem was that it was at the other end of the hospital from the labour ward, and as you know, obstetricians and gynaecologists are the same person, they're not two different people, and if there's a complicated case on the labour ward, to get to Ward 13, which is at the other end of the hospital, was 390 steps and 5 minutes walk. 5 there and another 5 minutes back. So if you've got someone complicated, so actually the patients on Ward 13 weren't getting a really good service because the doctors were very reluctant to leave the labour ward. We looked at the number of complaints, and actually the women didn't really complain. Because they were losing the babies and they were very grateful for the service that we were offering. Just one lady said that she wanted to speak to the matron from the ward, and she'd had a contact with our PAL service, and the matron went out and listened to the lady's complaint. She didn't make a formal complaint, it was just a verbal complaint, and she just said that she was, although she was very grateful for what everyone had done, she wasn't really happy with the service that she'd had. There was a total lack of space and of resources on the ward. This is the day room at the far end, and often we'd have to sit ladies that were losing their babies in the day room, close the doors, not allow anyone else in. And this is the treatment room where they put a bed in, because there wasn't any side rooms for these ladies to go in to lose the babies. So it was absolutely devastating. And Helen, our staff nurse over here, actually wrote a reflection. Now I'd love to share the reflection with you, but we'll be here all afternoon. So what I'm going to do is I'm just going to give you a first paragraph. So thank you for giving me the opportunity to write down my feelings about our closure. I hope you don't regret it. Even if you don't get past page 1, I feel that I have some closure, and it has been a therapeutic experience for me. So what Helen found was that as a gynae nurse working on a busy surgical ward, she was well out of her depth, as were the surgical nurses looking after gynae patients. They were well out of the depth. And I know that particular one instance, there was a lady that delivered, and there was nowhere for her husband to go. He was found stood at the door to the hospital, to the ward, grieving and crying, and really quite upsetting for everyone, patients, staff. So that's why we decided to take this project on. So we used lots of lean tools to look at what we got. So we mapped the process as it was, and there was an area called the Early Pregnancy Assessment Unit that was on the day case unit, where ladies went, they were booked into, and there were 4 scan slots, and they could go and would be scanned, and but it was more planned. These Ward 13 looked after the ladies that walked through the door with abdominal pain or bleeding. So we mapped the service on Ward 13, and we mapped the EPAL service, and we mapped what it used to be like as well on Ward 18, and we came up with this fantastic, we thought it was a fantastic idea, didn't we? Fantastic idea to have this all singing, all dancing gynae unit where we would look after every woman, whether they were coming in for an elective operation or whether they were coming in because they were bleeding or losing their babies or they got abdominal pain or something like that. We've not quite got there yet because it's about improvement, so we're getting there. So we're still stepping up to there, but we've done really, really well. We've got standard operating procedures within the unit now to deliver the service. We did 5S and redesigned the new area, and we did a 5S on Ward 13. And Ward 13, when it was a joint ward, was not engaging with the productive ward, and every other ward in the hospital was, except this ward. That was because the morale on the ward was really, really low of the staff. Once we moved off, the morale changed. We did capacity and demand to ensure that we got accurate figures and systems for claiming for care given, because what we found was we weren't claiming income. So if you came in at night or during the weekend, you didn't get into the system. So we did a little audit, and we had 37 patients that came in either at night after 5 o'clock or at weekends, and they weren't anywhere on the PASS system. And that, at £76, which is the bog standard rate, £2,815 lost income every month. That was, and we then delved a bit deeper and found that actually some people were actually going to theatre and having operations at weekends, and they were home by Monday. We don't think we were claiming that income either, because no one would answer my question. If a patient's been to theatre and they're on the theatre system, do we claim from that income? Do we claim from the theatre system? And nobody could answer me that question. So in a 6-month period, we think 6 people went to theatre without us claiming any income. We really struggled with the general managers to get them to understand, because obviously they'd made a big decision to close this unit, and actually getting them to understand that we weren't giving these women a really, really very good service at all. So we used DMIAC to write a paper, and we presented that to the general managers, and the general manager came back and said, find me somewhere where you can do it. I think that was what she said, was it?
Yes.
Find. So I went and got Sherry and said, come here now, what do we need to do? And we looked at everything and came up with an idea. We had to take it to the director of nursing at the time to actually get it moved forward, because it was about patient safety and about patient care. It did have a little bit of income in it because they were losing income, but that wasn't the driving force really. It was about the care of patients. So we got somewhere when we took it to the director of nursing. So here's our maps. So that was the current state. Pathway 1 was the EPOW pathway. Pathway 2 was the pathway on Ward 13. And the pathway at the bottom is our redesigned pathway. We pulled ourselves together an action plan, and we worked through the action plan and created a unit. And I'm just going to hand over to Sherry now, if I can move this.
Let's see if this will stay on. No, I can't do it. I'll just hold it. Thank you. As Sue's already said, we started off not with a vision for how it would look like in 12 months, 2 years. We started off with a belief in how we wanted to care for women. Right? We didn't have all the answers. We certainly didn't have all the space. But what we had was a burning desire to do something. So Sue's already said, my background is day surgery, and I had this fabulous Ward 20, which is a really, really nice day surgery unit, directly opposite labour ward, so location-wise, perfect. It had been recently extended because of the single-sex accommodation things, so, and I had one room, the EPOW room, which was left behind when gynae services got moved. So I had one room and one waiting room. Clearly not big enough for the hundreds of patients, but we had somewhere to start from. So that's what we did. Helen was redeployed to me, weren't you, Helen? 3 days a week, and we started small. We started bringing ladies. We had 4 scan slots in the morning, so we had the afternoons spare. We had to rejig things around, but that's where we started from. And initially, we increased our scan slots. We knew that we were based opposite labour ward. The doctors were happy. Very importantly, we started putting in safe systems for collecting data based on the day surgery methodology, and we had dedicated staff. Now, historically, I've always liked to rotate staff to remain flexible, but for this project, I knew that we needed dedicated staff who had the right ethos. Phase 2, after a few months, we soon outgrew that, so it was very good because I'm the matron for the area. I was able to co-opt one of our 4-bedded bays in the day unit. That in itself caused loads of problems with the day case patients because their families weren't allowed to stay because we have 50 of them and couldn't have 100 patients in the people in the area. But for our clients that were coming in that needed that support, we needed somewhere that dads, mums, significant others could actually stay with the women. Wasn't ideal, but we used it. I was absolutely delighted to be able to appoint a dedicated gynae CNS to lead this service moving forward, and we've actually now got Jackie trained up to do hysteroscopies, and she's going on to train to do colposcopies, so we're coordinating the whole package of care there. And then in phase 3, when we outgrew that, and we did this rapidly, I was able to take over one side of Ward 20. And now we have what we call GATU, which I'm sure is was led on by Cake at one point, but the Gynae Assessment and Treatment Unit. And for that, we have a dedicated area on the day case unit, but it is a separate unit. Right, as the doors don't open, let's let people in and out. We have all single rooms, we have a sitting area, and we have enhanced privacy and dignity. Right, so when we started off, you saw in the first thing, it was a day room and a little treatment room. Then we moved, this is Shirley here, she had a office and a waiting area. Then we moved to the 4-bedded bay, and we got our CNS. And now this is our GATU unit, which is an arm of the day unit, but it's isolated. As you can see, every nurse has their own office. So if somebody becomes distressed during a consultation, they're not waiting for the next person to come in, we can move and flex about. There's a private waiting area, we have ensuite bedrooms and side rooms for them, and just recently the team turfed out the bathroom and turned it into a sitting room so that we could have yet another patient area. Key to health at the moment is actually being paid for what we do, and we knew that we were hemorrhaging money beforehand. We now have set up with the PCTs telephone calls for advice, so it's auditable. We know exactly what the advice that we're giving to women and families, and we're actually receiving payment for it. And we actually capture all our activity now, so there's dedicated care plans within for each case coming through. We've moved the termination of pregnancy outpatients down into that area as well, so that women aren't sat in normal gynae clinics, therefore giving them privacy and dignity. And importantly, we can fast track our patients through from A&E. So at really, really busy times during office hours, what they will do is the A&E consultant will just ring up and say, I'm sending Sherry Herp down, is that okay? And they're received straight through, so no more 4-hour waits at all. And GPs can refer straight through as well if they feel it's necessary. So all in all, a much more improved experience for the patients and for the nurses that work within that department and the medics as well. Right, I'll hand you back on to Sue.
So obviously you've got to look at what you do. So here we've got some graphs, and at the beginning this was the attendances, and it looks like it's down at the beginning, but that's because we weren't collecting all the information. Yeah, and the yellow bits at the top are the reviews, and the pink bits are the new patients that come through to the Gynae Assess and Treat unit. And as you can see, we're doing really, really well. This is a reduction in the non-elective gynae patients to Ward 13, which is the surgical ward. Before the Gynae Assess and Treat unit was opened, there was on average 66 admissions per month, and this is reduced to an average of 41 admissions per month. And that the next step is to open the Gynae Assess and Treat unit 7 days a week, 24 hours a day. so that none of the patients would ever need to go to Ward 13. And we've looked at the length of stay, because what I didn't tell you in the beginning was when you used to come in and you needed a scan, you could get an urgent scan as an inpatient, but we couldn't get it on the same day. So often the women had to stay overnight in order to get that scan. Sometimes they didn't stay overnight, they actually went home and came back the next day, but we pretended they'd stayed overnight. Yeah. Or stayed a whole weekend, because if you came in on Friday, of course, you couldn't get a scan on a Saturday or a Sunday, so you had to stay till Monday, which is not a great experience either, is it? Especially if you're losing your baby and you need to know what's happening. So actually, our bed usage has gone right down on Ward 13, and Ward 13 is a much nicer ward now. And that's it, thank you. There's just one thing I'd like to read at the end, which is the end of Helen's letter that she wrote when she wrote about her experience of being on Ward 13 as a staff nurse and what it's like now working on the Gynae Assess and Treat. And it says, "I am beyond thrilled that people are taking notice. I really appreciate the support I have had from the matrons, Denise and Sherry. Airedale is such a huge part of my life, and I now again feel that I can make a difference. I hope the unit makes you proud of our efforts." Helen. Thank you.
Thank you.